So for my case, I have a 50-year-old female who's gonna get a right elbow fracture surgery. She, by the way, I have no notes. She is 5'5", she is 100 kilograms, she's a BMI of 36. She has listed a history of hypertension, GERD, OSA, and smoking. I can see in her chart that she had a CBC and chem panel done a month ago at her PCP, as well as an EKG that was normal sinus rhythm at her PCP. And then a blood sugar taken by the nurse this morning. So I'm gonna go in to do my pre-op interview with her. I'm going to verify her name and date of birth. I'm going to introduce myself, and I'm going to ask if she verified the surgery and ask if she has had any other medical or surgical problems other than the ones that I listed that I went over with her. And she denies that. Talking to her, she knows what's going on. She seems oriented. She can move all extremities. I did check her sensation and mobility on that right arm just to make sure that the neuro is intact on her right arm, and as well as her Capri film. I then am going to talk to her about if she's had any murmurs, if she's had any stents in the past, if she's had any chest pain before. She denies all of that. Her heart sounds are normal. And then I also am going to listen to her lung sounds, and they do sound clear. I am asking her about her smoking history. She said that she smokes 2 cigarettes a day typically. She stopped about 2 weeks ago. She also has OSA, and so I'm going to ask her about CPAP or BiPAP. She does use that at home. She does use it every night. She did tell me her settings, and then she actually did bring it to the hospital, so we can potentially use that later. But no other history of lung issues. She has been NPO since midnight, she said. She said that her GERD is well managed on Pepcid. She doesn't have any liver issues. And then at home, she said that she's able to walk up a flight of stairs without getting short of breath or stopping. And so I also know I don't need to do any more cardiac workup because of that as well. And she's mobile at home. I would ask about, I ask about any like family history or personal history with issues with anesthesia that she knows of, and she denies both of those things. So I'm less concerned about MH. And then I know that she takes the Pepcid, and I know that she takes an ACE inhibitor for her hypertension, which is listed on her chart. But does she take any other meds? Does she take any supplements? Because I do need to know for her plan of care. And she said no. And then she did hold the ACE inhibitor this morning as instructed. Then I'm going to do her upper lip bite test. And I should say she's an ASA too, because her hypertension and her OSA are well controlled. The upper lip bite test, she's a class 1, Mallampati, without phonating. She was a class 3. I could only see soft and hard palate. And then her thyromental distance is 7 centimeters. Her inner incisor distance is 3 centimeters. She had full range of motion of her neck without any pain, and her neck is a little bit thicker, but her BMI is 36. And so then I'm going to go into my plan of care for her. I initially talked about an awake intubation with her, and she vehemently refused it. And so next plan, because of her GERD, that I would want to do an RSI with her. So I explained that I'd be giving her these meds that you wouldn't be aware, and then I would put the ET tube in, and I'd also say that we have to do an ET tube and general anesthesia for this case just to get enough anesthetic depth for the surgeon to be able to do the procedure. The risk with You know, her lung history and with intubation is that she could potentially have a prolonged intubation. So we talked about the risks with that. And I want to prevent aspiration, right? So that's why we're doing the RSI. And she was okay with that. And I also talked to her about wanting to do an infraclavicular block just to help with pain. It would be a needle, so there would be pain. There's a risk of infection, bleeding, or nerve damage, but I would be using an ultrasound to place it. And she was okay with that. And so I had her sign the consent forms. She didn't have any more questions for me. She verified that she'd already talked to the surgeon, said that she had signed something for that as well. And so I am now going to go do my machine check and my room check while my colleague does the block. And we talked about her getting 1 milligram of Versed beforehand, and she's also getting some IV pain meds from the nurses in pre-op. So I did ask that she was NPO at midnight, so no meds, she's just getting. Okay, so my wall pressure is 50 PSI, my E-cylinder is 1,000, I have suction set up, I have a working ambu bag, my vaporizers are filled, the interlocking system is working, my flow meters are working, the proportioning system is working. I would do my low pressure leak test, and then I would check my CO2 absorber, make sure I don't need to change it. I would then turn on my ventilator, I would check my O2 sensor, and I would calibrate it to 21 and 100%. I would make sure that I have all my monitoring equipment for my vital signs, all my alarms are in there how I want them. I would have had calculated out my ventilator settings and know what rate and pressures I want, and those are going to be programmed in. And then I'm going to do my high pressure leak test. So I'm going to include the Y piece. I'm going to have my APL valve completely closed in bag mode. I'm going to pressurize to 30 centimeters of water and leave that for 10 seconds, and then I'm going to turn my APL valve down to see that the gauge goes down as well. With the valve completely open, I'm going to test my scavenger, make sure that it inflates and deflates with my O2 flush button, and then I can switch to bag mode, and I'm going to make sure that my bellows is filled. It is rising and falling with the volume that I have set. My unidirectional valves are fluttering appropriately, and I can get a high pressure alarm and an apnea alarm from the test lung that I attach. And then I'm going to, since it's all passed, I'm going to switch back to bag mode. I have my APL valve completely open, and all my flows are off. And so now for my room setup, I am anticipating a difficult airway just from her malum potty and her upper lip bite and the thicker neck. And so I am just going to automatically plan to use the glide scope. That's plan A. Plan B is using my fiber optic. And so I have that, all that in the room, and then I have my tube loaded on my fiber optic so that I can just switch to that without having to mess around. I have a selection of masks. I have a selection of LMAs and oral airways in case that I choose to use those. Even those wouldn't be as good for the GERD. We shouldn't really use those in that situation, but I have them. I have an array of ET tubes from 7.0 to 8.0, and then I have my IV fluids primed and hanging. I have some warm blankets ready to go. I also have my meds pulled up, and so I have my apples, as well as I have the meds that I'm planning on using for this case. And so I have succinylcholine, that's 1 milligram per kilogram. She's 100 kilograms, it's gonna be 100 milligrams pulled up. Propofol is 1 milligram per kilogram, so I'm also doing 100 milligrams. I have 4 milligrams of Versed just to prevent nausea, as well as Decadron just for multimodal pain management and reduce swelling, and so that is going to be 0.5 0.5 milligrams per kilogram, and I have 50 milligrams pulled up, as well as a stick of fentanyl that I can use throughout the case for her. And so then so since my room is set up, I'm going to go get her now. And she's pre-medicated, she's got the block, it worked. So we're gonna come into the OR, and I'm gonna get her covered with warm blankets. I'm going to ideally ramp her for the sake of this video and how short I am. I don't have a stool, I'm not gonna do that. So I'm gonna start to pre-oxygenate her. I'm gonna put my oxygen just up to like 8 liters. And so she's at 100% FiO2, and I'm gonna leave her there for 5 minutes to give myself some extra time. So when that is done, I am going to push my propofol in the IV that she already had from pre-op. And I'm going to make sure that I can still ventilate, and I can. And so then I'm gonna give my sucks. And so now I'm going to test her lash reflex, and she doesn't have a lash reflex. I can put my APL valve to 20. She's easy to bag, so now I'm going to intubate her. So I've got my glide scope and my tube right here, all ready to go. I'm going to insert my glide scope, watching the teeth and sweeping the tongue to the side. And I have a grade 3 view, so I can only see the epiglottis. And then I'm going to put my tube in, and so then that goes in. So that was plan A. So if that weren't to work and I wasn't able to intubate, I'm going to put all that to the side. I'm going to pre-oxygenate again to give you some more time. I've got my APL valve turned up to 20 still, and I can give her some breaths. She's doing okay on the monitors. And then when I'm done with the pre-oxygenating, I'm going to grab my fiber optic that's already set up. For the sake of the video, I'm not going to fully do the fiber optic just because it'll take a minute. But I got the tube with that, and I'm going to inflate my cuff. I'm going to attach my ventilator, and I can see my ETCO2 reading. I can see condensation in the tube. I'm gonna bag. I'm going to hear bilateral breath sounds, and so I've confirmed placement as well as I saw it go through, the balloon go through the cords. And so now that I've confirmed that, I'm going to take my ET tube with dog-eared ends, and then I'm going to tape my eyes. And so now I'm going to switch into ventilator mode. I'm going to turn SIBO onto 3 for this case, and I'm going to make sure that she is properly positioned. So since it's the right elbow, and that's going to be in the field, I'm going to make sure that things look like they're padded enough for the surgery so that she doesn't get any pressure sores, but they have like the site exposed, and that it's less than 90 degrees. With my left arm, I'm going to make sure that it's supinated. I'm going to make sure that the arm is padded and it's tucked at the side, and then I'm going to make sure that she's got some padding that's not too tight under her shoulders and head, so she doesn't get any injury from that as well, and a slight bend in her knees. And then I have the warming stuff on, and then I can give my other meds. And yeah.
Good job. Nice.